Right, how are we doing for time? Now this says 3:36, so I have to either take away 4 or add 8. All right, good. Thank you. Yeah, you might say, why did he not adjust his watch to... It's all to do with, it's too complicated, but it's all to do with the steps, you see. You're trying to do so many steps in 24 hours, and it doesn't deal with time zone changes very well. Because, so it's a lot, I found with travel, it's a lot easier to leave this on currently British summertime. And yes, anyway, that's... Okay, so I'll give you an example of this. So I'm going to go into more detail next week about hepatitis C, because it's a particularly interesting one. But I guess most of you will know this, but maybe not all of you. Hepatitis C virus, it's a slowly, for most people, progressive disease of the liver. Again, the effects range, for many people, can be asymptomatic for a long time, or you could have quite mild disease, and that's 80% of those who are HCV positive are in that category, asymptomatic or mild disease. But at the more extreme level, you can get liver failure and also primary liver cancer. There's lots of different genotypes, 6 at least, and many subgroups in between. And the genotype pattern varies across countries. So for example, in England, those people who are HCV positive are generally GT1, genotype 1 or 3. And the other groups are not very common. I'm not sure what it is in Japan, but I know it's different. Part of me wants to say you've got more genotype 2. Any experts? No. Okay. That's quite relevant because to some extent different treatments work better, well, some treatments only work in certain genotypes, and other treatments, while they might work across genotypes, they may not work equally well across all genotypes. Now this area came to prominence really about five years ago, and it's because suddenly a new treatment came along that was much more effective than the existing treatments, and it was easier to tolerate. The evidence suggested not only was it more effective, better chance of clearing the virus, but also few or hardly any side effects of treatment, or sorry, adverse effects of treatment. And it was just a tablet per day, and 1 tablet per day just sounds just so easy. Also possibly for 12 weeks, although in some cases it's necessary to go for a treatment for 24 weeks. Well, that compared with the existing treatments, which typically were for, well, a lot of the traditional treatments were for 48 weeks and were much harder to tolerate and did have higher rate of adverse effects. And so this just changed things, changed the landscape of treatment abruptly, and it's great news. When it was launched, its price in the United States was $1,000 per tablet. Now that's quite a lot of money. UK price was a bit cheaper, £400, but still that's quite a lot of money. Now, that's quite quite a challenge for a health system. You could argue they should have seen this coming, they should have planned better, but that's hindsight. And so all around the world, country after country, faced a major challenge. This was a condition which was hard to treat. The existing treatments were, well, if you could put up with the treatment and see it to the end of your 48 weeks, existing treatments were probably clearing the virus in 45 to 50% of cases. Slightly newer treatments had come along and they'd got that rate up maybe to 55, maybe approaching 60%. This comes along and suddenly it's a treatment that virtually anybody could tolerate, and clearance rates 90%, 95%. Indeed, more recent evidence, some of the studies suggesting almost 100% clearance of the virus. Now, it used to be the case in many countries that we almost didn't, well, it wasn't that we didn't treat HCV, but we didn't try very hard. Because, particularly in a lot of countries, the patient group that were suffering mainly were intravenous drug users. They're not the only group, but they were quite a large group. And these individuals, this is a terrible generalization, they have fairly disorganized lives, and so sticking to a tight treatment regimen for 48 weeks is just beyond many of them. And so for that reason, particularly in England, we weren't treating very many patients with HCV. And we were treating some, but there had to be patients where the clinician felt, yes, they could stick with this. There's a chance they can follow the treatment. I guess in Japan, a little bit different. My understanding is most of your HCV comes from a vaccination campaign back in time when there was a certain amount of reuse of needles, innocent reuse of needles, just there wasn't a recognition that you might actually be spreading disease. And so it's not quite the same group of patients in Japan, although also your intravenous drug users will similarly have high rates of HCV, but this is the sort of general population would also be affected. And so to give you a sort of idea of what economics can offer, in England, there's an organisation, NICE, National Institute for Health and Care Excellence. Sorry, I shouldn't move around too much. I keep forgetting. I was just checking he was still awake. Yeah. And yeah, NICE make decisions about new treatments for the NHS. And if NICE make a positive recommendation, the NHS must make the new treatment available. If NICE don't recommend, NHS can provide a drug, but they don't usually because they haven't got the resources. And so a positive recommendation from NICE is very important. And so what NICE looked at, it's sofosbuvir, that's the name of the drug, and we looked across different genotypes. So there's, remember, genotype 1 and 3 are the main ones in England, certain one to genotype 2, 4, 5 and 6, not very many. Another distinction here is, are you naive to treatment or have you experienced treatment already? Experienced and probably failed on treatment, presumably. Another distinction is also, are you interferon eligible or interferon unsuitable? Interferon at the time, pegylated interferon, was the main standard treatment. And another distinction, how far had your liver disease progressed? Was there any sign of cirrhosis yet or not? as the disease progresses, if you continue to progress, you develop cirrhosis of the liver. And so we were able to distinguish all these different categories, and these are the recommendations we came up with. Now, green, this is green for go, that's recommended. Red for don't do it. And let's have a look at this. So if we look at the, I won't go through them one by one, but just get a flavour of it. So genotype 1 was a large group in England. If you were naive to treatment, the calculation was that compared to traditional treatment with pegylated interferon and ribavirin, sofosbuvir, adding that in as a treatment, could produce additional quality adjusted life years at the cost of 15,000. So that 15,000 means if we introduce sofosbuvir for this patient group, we are going to gain additional years of life, but the idea of a quality adjusted year of life is trying to take into account the health state the patients are spending time in. So you might think of it as a year of healthy life, if that helps. So you could gain a year of healthy life for £15,000 on average across patients in this group. On the other hand, if they were unsuitable for interferon, introducing the treatment produced a gain in QALYs, but at £49,000 per QALY. And so a judgment is being made here that 15,000 is a price worth paying, £49,000 per year of healthy life is not a good one to pay for. We didn't have any data on treatment experienced GT1 patients who were interferon unsuitable, but given that that figure was 49,000, we anticipated it would also be quite high, and so also said no to that group. Moving on, for example, just GT3, this other big group, at least in England. Again, the treatment naive ones, it looked as if across all the patient group, so this is all the GT3 naive to treatment, if you're interferon eligible, the cost per QALY would be 21,000. And again, that was thought in the case of patients who had cirrhosis, it would probably be a bit lower, but if you had no cirrhosis, probably a bit higher. On average, 21,000. The difference here between cirrhosis and no cirrhosis is if you've no cirrhosis, you're sort of earlier in the pathway, and there's going to be a longer period of time before you develop the more serious problems. If you already have cirrhosis, you're much closer to getting the serious problems, the liver failure or the liver cancer. And so decision here was, yes, we could recommend it, but to those who are later on in the pathway, those with cirrhosis. And at the time, stress this is back then, a few years, if you were unfortunate enough to be GT4, 5 or 6, at that stage, there wasn't enough evidence really supporting the use of the treatment. And so you get this sort of pattern of results. You get evidence on the likely benefits, the likely costs, and you're able, if you so wish, to say, all right, these groups will get the new drug. These other groups, it doesn't seem to be good enough value. Now I stress that it's not economists deciding that. It's economists and statisticians and others interpreting evidence, developing an economic model, producing these results. The decision is by a much more broader based group as to whether to go with that.